Welcome again, and thank you for joining Elder Voice Advocates webinar. I'm Chris Sundberg, and I'm Executive Director of Elder Voice Advocates and Elder Care IQ. We're here and we're delighted to have Eilon Caspi, who's a PhD in gerontology and a dementia behavior specialist. He worked in the aging field his entire adult life, as well as an educator, applied researcher, consultant, author, and elder human rights advocate. Over the years, he's conducted several research studies on various forms of elder mistreatment in long-term care homes, such as injurious and deadly neglect, psychological and physical abuse, fatal resident-to-resident incidents, self-neglect, fear of retaliation, financial exploitation, and thefts of opioid pain medication. The ultimate goal of his work and applied research is to enable vulnerable and frail elders with dementia to realize their human right to live with dignity in a safe care environment. Additionally, Eilon is a member of the Elder Voice Advocates Board of Directors. Here to present unwanted a discussion about deadly entries into bedrooms of long-term care homes is Eilon Caspi. Thank you, Eilon.
Thank you, Chris, and thank you for hosting this webinar today and for the wonderful introduction. Today, we are going to talk about the particular aspect of a phenomena that has been a source of concern for decades, and I've been focusing on it in various ways over the past 15 years. The general phenomena is distressing and harmful resident-to-resident interactions in long-term care homes. And the specific aspect on which I'm going to focus today has to do with unwanted entries of residents with dementia into the bedrooms of other residents and the consequences of these entries. Towards the end, I'm going to talk about some directions that care providers should consider in addressing this phenomena. I don't have all the answers, but I hope that it will help raise awareness to this phenomena and encourage care homes to take this phenomena seriously. I will also share very disturbing incidents, some of them with very graphic descriptions. So I just wanted to mention it ahead of time. And also at the very end of the presentation, you will have a list of studies, reports, and newspaper articles for those of you who want to dive in further in learning about this phenomena. So before talking about it, I want to mention that I honestly believe that the majority of people who work in long-term care homes are caring and dedicated and compassionate individuals. And they are heroes, and they were always heroes decades prior to the pandemic. And also that all of us make mistakes. And I want to recognize that as reported extensively in an Institute of Medicine report over 20 years ago. Kind of general observation about behavioral expressions among people living with dementia that are often labeled and often mistakenly labeled as aggressive in general and in those care settings. So I believe that these are expressions of unmet human needs oftentimes. They do have meaning and purpose and function to the person, even if the person may not be able to articulate it in words. They're attempting to communicate something important that we need to explore with validation, as Judy Berry tells us, and also as part of the validation method of Naomi Feil, which is a communication method with older adults with Alzheimer's disease. What's actually happening oftentimes is that they're trying to gain control over unwanted frustrating, frightening, or threatening situations. They're attempting to preserve their dignity, identity, and personhood. And in a way, those behavioral expressions could be helpful because they can serve as barometers of the resident's tolerance level to stressful stimuli, which should guide preventative strategies. Here is a definition of the general phenomena of resident-to-resident incidents. Here on, I'm going to use the acronym RRI. Negative, aggressive, and intrusive verbal, physical, sexual, and material interactions between residents that in a community setting would likely be unwelcome and potentially cause physical or psychological distress in the recipient. And I underlined the word in a community setting because, as Professor Mark Lux from Cornell University said, if someone would walk into my office one day and out of the blue said, "Mark, blank you," meaning curse him, he would have to lie down for a couple of hours to recover from it, let alone if someone would lay a hand on him. But for some reason, in long-term care homes, this phenomena has been largely normalized with dangerous consequences, as we will see today. If I had only one slide today, I would use the 3 words, fighting for dignity. And the reason is because after studying this phenomena extensively and reviewing the research and praxis literature and conducting hundreds of direct observations in secure dementia care homes, what the real story is that residents with the serious brain disease, such as Alzheimer's disease, are fighting with each other in an effort, sometimes a desperate effort, to preserve their dignity, which is defined as the quality or state of being worthy, honored, or esteemed. And when residents sense that their dignity is under threat, they may react in ways that could be classified or labeled as aggressive. This is also the title of the documentary film that Judy Berry and I did a few years ago, which we call Fighting for Dignity, which include our interviews with 3 families of individuals that were seriously harmed in those incidents, 2 of whom lived and received care in Minnesota. You can access this film on Terra Nova Films. If I had 2 slides, I would say that the most critical factor in improving conditions in care homes is having a sufficient number of direct care staff members that are, I should add, well-trained in providing care to people with dementia and in understanding the risk and protective factors and the preventative strategies for this phenomena. And indeed, a study at Cornell University demonstrated a relationship between low staffing levels and higher rate of these incidents. Not surprised there. A little bit background about the prevalence and incidence of this phenomena. So the National Center on Elder Abuse stated a few years ago that this phenomena is more common than physical abuse by staff. Several research studies have shown that the phenomena is very common. For example, the studies noted in the middle there demonstrated that during a span of 1 month, 1 out of 5 residents was involved in one of those incidents. An early groundbreaking study at Harvard University in nursing homes discovered that nearly 300 residents were physically injured in a single year in Massachusetts. And even if you would you use a conservative estimate extrapolation to national, you would easily get to 14,000 physical injuries nationwide. And granted, a substantial portion of these would not be serious injuries, but still, every injury could also include psychological harm, and they also could escalate further down the road into more serious harm. A research study here in Connecticut has shown that these incidents were considered the #1 reason that police were called to nursing homes in the States. In Minnesota, investigative reporter Chris Sears of the Star Tribune discovered that in a single year, there were over 4,000 complaints related to this phenomenon, complaints that did not result in serious harm, that were not investigated by the Minnesota Department of Health during that year. And it was the second highest, close second highest, only after Falls, under Falls with 4,128 complaints. Thousands of complaints are not investigated. So much maltreatment continues, and less severe issues may escalate to more serious harm. And I think it goes back to the importance of a culture of learning. But what are we learning from those incidents to prevent incidents in similar circumstances? And here there's a tragic incident in Minnesota, and the daughter said, if my mother had not been pushed by another resident, she would still be alive. After the incident, the daughter contacted the assisted living in an effort to ensure that will not happen to other residents. And that's a theme that I'm seeing over hundreds of injurious and fatal incidents that I examined over the years, that after it happened, after the devastation that the family experiences when they're learning about those incidents, their requests, they're yearning for, they're asking, they're begging that this will not happen to other residents. Extensive review of the research literature found that these incidents represent 1/3 of all reported abuse cases in long-term care homes. In Canada, in a single year, over 10,000 incidents were identified a decade ago. And we know that the United States is much bigger population-wise relative to Canada. North of the border from Minnesota, before the pandemic, a very disturbing report called Situation Critical discovered that there were 27 fatal resident-to-resident incidents in Ontario province over a span of 5 years. But this phenomena, as I mentioned earlier, also occurs in assisted living residences. A national study discovered that this phenomena may be prevalent in this sector as well. Quick note about newly admitted residents. A study in Canada with over 300 people that were admitted to 3 long-term care homes in Ontario found that nearly 1/4 of those newly admitted residents were involved in what was classified in the study as aggressive behavior towards another resident, which invites the need to conduct pre-admission behavioral screening and also to use tools that were developed in research to detect it during admission and inform the decision as to whether to admit an individual, and if you admitted the resident, to develop an individualized care plan to keep the resident and others safe. We also know that the majority of those incidents are not reported in most nursing homes, probably also in assisted living residences. And we also need to think about the low and poor quality of documentation and reporting. And we know that these incidents are under-investigated internally and externally. Dorothy Stultz lived in Nova Scotia in a care home. She was pushed by another resident and died as a result. This fatal incident was not made public in Nova Scotia. Her daughter wrote, "It is shocking that the information never left the care home and got to the higher ups, where it could have been seen, more closely looked at." The daughter expected the health department would try to learn from the tragedy. We also know from research studies that many incidents are not witnessed by staff member. One study in a small care home for people with dementia found that nearly 40% of resident-to-resident physical incidents were not witnessed by staff. A study in Australia showed that the majority of entries into another resident's bedroom were not witnessed by their care staff members. So when an individual develops Alzheimer's disease, one of the manifestations of the brain disease is often spatial disorientation, also called visual-spatial disorientation, which is defined as misperceiving immediate surroundings, not being aware of one's setting, or not knowing where one is in relation to the environment. And as a manager said about a resident who struggled daily, every hour, to find his room, to find the bathroom, to find the dining room table, to find the area where the meaningful activities took place, she said, "It is scary how debilitating it is." And I want to recognize it, this phenomenon, the visual spatial disorientation, as a disability, and to make it very clear to everyone that it has serious, far-reaching, serious emotional and physical consequences on residents, whether it's anxiety, fear, embarrassment to ask for help when they can't find their room. And also physical consequences. If you can't make it to the bathroom, you can imagine what are the consequences on your ability to control your bladder, for example, over time. I want to state that the ability to reach desired destination is a basic human right. And nearly a decade ago, I published a study on wayfinding difficulties among people with dementia in 2 secure dementia care homes in Massachusetts. And my article provides a comprehensive overview of this phenomenon, those of you who are interested to learn more about it. But kind of to move beyond abstract statements, moving from one point in your house to another, it's something that many of us take for granted. But we know that it may be up to 11 cognitive abilities required to complete routes in care homes. And if we're going to go clockwise, starting with the yellow highlighted step there, and move along the process of a resident trying to get from point A to point B in the care home. It starts with recognizing the need. You need to be able to recognize the need to move to a different location. You need to plan it, to initiate the walk. You need to, while moving, you need to locate your position relative to the physical environment. You need to retain in your memory the purpose of the walk. You need to filter irrelevant information on the way, not get distracted from occurrences and objects along the way. You need to be able to correct yourself when you take a wrong direction, a wrong turn. You need to identify the destination. You need to be able to recognize that you want to stop there, and you need to recall the initial purpose of reaching the destination. And when you have Alzheimer's disease, especially in the mid to late stages, this could be various steps in this process could be very, very difficult and challenging, if not impossible, for certain individuals. I want to kind of zoom back out and share some findings from the first study in the United States and Canada that I conducted on fatal resident-to-resident incidents. A phenomenon that is shockingly not being centrally tracked by CMS in over 15,000 nursing homes nationwide. So I tracked 150 newspapers from multiple countries, and I reviewed dozens of death review records by coroners from Ontario, and I systematically analyzed them. And while the majority of the fatal incidents occurred in nursing homes, a quarter took place in assisted living residences. And you can see the breakdown of the countries at the bottom of the slide. In terms of the characteristics of residents involved in these incidents, the residents who died, on average, were nearly 10 years older than the residents whose physical contact led to the fatal injury. Men and women were equally died during these subsequently to these incidents. But 3/4 of the residents whose physical contact led to the fatal injury were men. And this is consistent with the long research literature on what is called or labeled aggressive behaviors in older adults and those with dementia. I also was able to tie back 23 deaths to newly admitted residents, which I defined in my study between admission and 3 months later. In terms of the circumstances surrounding the deaths, nearly 60% of the fatal injuries took place inside bedrooms. 43% of the incidents between roommates. 44% during the evening hours, another 14% during the night. 38% took place during the weekend. Reportedly, 62% of the incidents, of the fatal incidents, were not witnessed by staff members. The nature of the physical contact, 44%, were characterized as pushful incidents or head or face beatings, with 22% for the latter category. And in nearly 1/3 of the incidents, an object was used in the physical contact that caused the fatal injury. And you can see here the nature of the physical injuries, whether it's brain injuries or hip fractures, and the breakdown of the causes of death. On average, slightly more than 2 weeks between the incident and the passing of the resident, but 1/4 of the residents died on the same day, which can tell us at least 2 things. One is the vulnerability and the frailty of the population, and second, the severity of the injuries. Some common triggers identified in my study: invasion of personal space, very common; unwanted entries into one's bedroom or bathroom; taking personal belongings from another; reaching a breaking point; and conflicts between roommates. And the underlying theme: unmet human needs and situational frustrations. Professor Lynn McDonald, who studied this phenomena, said, "You wouldn't want to live in a place where you're afraid someone is going to come in your room and hit or hurt you. You and I wouldn't want that. Why should anybody in a nursing home?" In this section, I would like to describe a series of fatal incidents and the circumstances surrounding them. Dwayne Walls was an accomplished investigative reporter for many years. He won many awards for his reporting work. Later in life, he developed Alzheimer's and he lived in a nursing home in South Carolina. One evening after 9 p.m., he walked into another resident's bedroom and climbed into his bed. A resident with dementia, whose bed was taken, walked in. He saw Dwayne there, and he picked up his cane and repeatedly beat Dwayne. Dwayne was found severely injured, bleeding, unconscious, in a fetal position on the floor, with the man still beating him. He died a week later. His wife was completely devastated, as you can imagine. But she was told for a number of days that he only fell. It's only when she came to visit. She offered to come when she got the first phone call. But it was only when she came to visit him that she discovered the truth about what happened to him. The ombudsman discovered that there were understaffing around the time of the incident. And what was written on the death certificate in terms of the cause of death? Pneumonia. In Toronto, Frank Piccolo was a beloved science teacher. Late in life, he developed Parkinson's and dementia. After 8 p.m., a resident with dementia entered his bedroom. He hit Frank repeatedly over the head with an activity board. His condition declined and he died 3 months later. His wife, Teresa, said, "My husband couldn't defend himself or yell for help." Nancy, in a memory care home in Florida, I really recommend not using the term memory care. That's why I put it in quotation marks, because nursing homes and assisted living residences care for human beings and not for memories. But it's good for marketing, I guess. So she had a history of entering other residents' bedrooms and getting into their beds. One night, around 1 a.m., she entered another resident's bedroom and got into his bed. He became mad, struck her, put her in a chokehold, and strangulated her to death. I do not know the diagnostic background of the resident who did it. In New York, Friday evening, a resident A enters resident B bedroom and an argument develops. Resident A repeatedly smashes resident B's head on the concrete floor. He was pronounced dead at the scene. An employee said, "This is a shock to everybody. I couldn't leave work because everyone was crying. What went wrong? Why? Why here?" In a care home in Ontario, a personal support worker heard screaming coming from inside resident A bedroom. The aide found resident B punching resident A, who sustained facial injuries and was covered with blood. The resident suffered subdural hematoma, a brain bleed, and he died 2.5 months later. At Baycrest in Ontario, Canada, staff told Mayor's family, his sisters, that he had fallen twice. Security camera footage, which the family said it had to wait for 6 months to watch, told a different story. Mayor was standing guard in front of his bedroom. A physical struggle developed, he was shoved, and he died 4 days later. James Acker had Alzheimer's disease and he lived in a care home in Dundas, Ontario. He was attacked in his bed on a Saturday after 2 a.m. by a resident with dementia. He died a number of months later. If this happened to a child at Sick Kids Hospital, people wouldn't stand for it, his daughter said. Staff even tried to stop it, but was unable to do so until police arrived, which brings the need to pass mandatory behavior emergency courses and safe physical de-escalation strategies as a requirement in all nursing homes and all assisted living residences nationwide. Here are links to some courses that could assist on this front. But the training is not only for all employees, direct and indirect employees and managers, but also police officers. A recent investigative report by the Marshall Project revealed injurious and deadly interactions between police officers trying to arrest people with dementia. It was also published in USA Today. Teepa Snow, a national expert, has a DVD for first responders. I recommend watching it. It's a little old, but there's great recommendations there. For care providers, direct care staff members, nurses, social workers, there's an old DVD and the language in it is biomedical and stigmatizing. However, the techniques demonstrated in it are excellent and they can literally save many injuries and deaths. You can access it on Terra Nova Films. In England, Jessie had mild dementia. She was 91 years old. Early morning hours, she's being pulled out of her bed by a man with dementia. He punches and kicks her. She dies 2 months later. In Australia, 3 a.m., two women with dementia, one hit the other one with a plastic-covered chain with metal magnets while she was asleep in her bed. She was helpless in her bed and unable to escape. One person stated that she was probably terrified during the attack. She was left bleeding untreated and undiscovered for 2 hours and 15 minutes. The wounds to her arms were so deep they revealed the bone. A registered nurse said she looked like she'd been in a war. She died the following day. And yes, there were multiple warning signs that could have helped prevent this terrible trauma and tragedy. In New Zealand, Leonard was 99 years old. 1 year short of 100 years, he lived with dementia. Evening hours, a resident entered his bedroom. Leonard said, get out, this is my room." When staff arrived, he was already knocked unconscious. He died a couple of days later. In North Carolina, assisted living secure memory care home. A resident with dementia died. And this is the story. Another resident with dementia engaged in 27 incidents against resident staff and objects, which is why I put 27 dots there. because each one represents a warning sign. And then, of course, on a Sunday at 6 a.m., he was attacked in his bedroom by that same resident. The two shared a bathroom between their bedrooms. He sustained 2 neck fractures and suffered excruciating pain. He died 6 days later. A state inspection report cited assisted living with the highest level of violation for failing to supervise care. The assisted living claimed exempt from legal liability under the state's COVID-19 pandemic immunity law. Eventually, the wrongful death lawsuit was settled out of court. Recently, a serious in Arizona Republic reported an injurious and deadly incident between residents called the Bitter End. Unfortunately, it's only accessible to subscribers of Arizona Republic and USA Today. One of the residents that died and reported in this series was John Thompson, who lived with dementia. Another resident, 93-year-old, also lived with dementia and suffered severe PTSD. Thompson wheeled herself into her bedroom and she beat Thompson with 2 wire hangers. By the time staff pulled Thompson out, her blood was spattered against the wall and the carpet. You can watch the YouTube video showing the police camera footage when they arrived at the nursing home and collected evidence about it. It also includes an interview with the daughter who was completely devastated in the way she lost her mother. A nurse at the hospital asked Thompson's daughter, "Do you know what happened?" The daughter, "No, I have no idea." "Your mom was attacked by a fellow resident." The daughter's reaction when she saw her mother in the hospital was, "It's like someone took a flipping ice pick to her face. It was terrible. I was knocked to my knees. I will never forget that side of her." The daughter quoted her mother saying, "I am scared and I'm hurt. I'm afraid. I can't defend myself against this attack." The Geriatric Long-Term Care Review Committee that reviewed dozens of fatal resident-to-resident incidents over the years for at least 25 years, and I read each one of them. In a report a couple of years ago, there was an incident between 2 residents with severe cognitive impairment. Resident B repeatedly entered another resident's bedroom over 3 months. And resident A pushed him because he came into his bedroom and took his cookies. The resident suffered multiple rib fractures and subdural hematoma and died 2 weeks later. The review committee stated that it was struck by the normalization of these incidents. And for the first time, I've seen it using the term a sense of learned helplessness as experienced by staff members who are tremendously challenged in addressing these incidents. And in another fatal incident that this committee reviewed, after a 90-year-old woman with advanced dementia, stages of dementia entered another resident's bedroom, the committee wrote, "Perhaps in the future, technology will be able to assist." So yes, we need to develop, use, evaluate, and fund assistive technologies. And here's an example of a technology that was developed in Canada, but is also used in the United States. It's called Vigil Memory Care System. And I can connect you directly with their CEO if that's of interest. I would also love to hear from you, whether you're aware of any effective methods and technologies that could assist staff in recognizing in real time that the resident is about to enter another resident's bedroom and prevent another injury and death. And families are asking, we want to see a solution. We don't want the death of our father to be in vain. I want to see something done so this doesn't happen again. This is a son of a resident with Alzheimer's who died 4 days after being pushed by another resident with dementia in Canada. I want to dedicate a couple of minutes to incidents that are characterized as push-fall incidents. And I think one of the main messages of today's presentation is that really all you need is one push. This is a very vulnerable and frail population oftentimes. And 3 studies, including mine, show that push-fall incidents constitute between 44% and 63% of fatal resident-to-resident incidents. So how can we instill it in direct care staff minds that all you need, literally all you need is one push, when residents' impact with the floor after a fall can result in a hip fracture, and or brain injury. And from there could be a cascade of medical complications and deaths. I was curious, so I picked up the last 3 batches of reviews by the Geriatric Long-Term Care Review Committee in Canada, in Ontario. 10 out of the 12 most recent fatal incidents reviewed by the committee, that is 83%, were push-fall incidents. I want to dedicate a couple minutes to the dangerous normalization of this phenomenon. There you see Mayor trying to guard his bedroom from another resident at Baycrest in Ontario, Canada. 4 days later, Mayor was dead. Professor Joseph Ibrahim, who studied these fatal incidents in Australia, wrote that your life is worth something no matter how old you are. If you die a week before you had to, that week could be a really precious week lost. Professor Gloria Gutman, who is extremely concerned like myself about this phenomena, wrote, up to now, the issue had been one of indifference, that these are old people and they're going to die anyways. Somehow, in a collective setting like a nursing home, the abnormal becomes normalized. And again, the Geriatric Long-Term Care Review Committee in Ontario wrote, after years of reviewing those fatal incidents, providers have become accustomed to those incidents and accept it as normal. Some managers have lower level of concern, which results in disastrous outcomes. Moving to the last section of this presentation, I want to just bring up some areas for consideration. The first thing, as always, is we need to raise awareness to the potential consequences of unwanted entries into bedrooms in long-term care homes. We need to break the silence and dangerous normalization of this phenomenon. We have to remember and remind ourselves and remind staff members that they are working in residents' homes. It's not that residents live in staff members' workplace. Residents' bedrooms and bathrooms are the last frontier of privacy. This is a human right issue. It's their right to remain safe in their bedrooms and bathrooms. Do you expect to be safe in your bedroom, in your home? We need to eliminate the stigma and be very careful before using the terms aggressive, abusive, and violent to describe older people with a serious brain disease such as Alzheimer's disease. And I wrote an article in The Conversation to make that case. We need to focus on the whole person with his or her rich lifelong history. And here's a link to a piece I wrote with 20 reasons why we need to know the early life history of people living with dementia. We need to anticipate and proactively meet each person's varied human needs. We need to proactively create emotional well-being. We don't need to only talk about safety. We need to also talk about human flourishing at the end of one's life. We need to treat direct care staff as the bedrock of the long-term care sector and put real meaning into the word heroes. And the roadmap could be found at the what it used to be called the Paraprofessional Healthcare Institute, or PHI, in New York. They have 30 years of resources to help us navigate and get there. We need to ensure that there are safe people-to-people levels at all times. I don't like the word staffing levels because these are people caring for people. And these ratios need to be adjusted for acuity level. It has to be mandatory and enforceable. We must provide special education, orientation, in-service, experiential learning, which means on the floor as it happens in the evening hours. Oftentimes you come and managers are not there. You come in the weekend, no managers. Direct care staff need supportive guidance, as Nancy from Elder Voice Advocates coined that term. Supportive guidance. They need supportive guidance from experienced and qualified managers. And they need to be trained, as I mentioned earlier, in emergency de-escalation strategies. And providers must invest a lot in recreation departments and provide personally meaningful engagement to each and every single individual in the care home. This is one of the biggest secrets for the prevention of this phenomenon. And again, evenings and weekends are vulnerability time periods, as shown time and again in research studies, including mine. Just want to give a shout out to a free training program, Train the Trainer program, offered at Cornell University specifically for this phenomenon. You can reach out and make sure that your care home staff and managers are educated with the strategies offered in this program. Again, 3 studies showed that evenings are vulnerability time periods. And while meaningful engagement is a key for prevention, the reality is several research studies have shown most residents are not engaged in meaningfully most of the time. And boredom is really the enemy of a subgroup of residents with dementia. They become restless, anxious, and things often go south from there, including with this phenomenon. And as an administrator of a nursing home told me once, a resident most at risk of an assault is bored. If you're looking for an excellent resources related to people with dementia, I highly recommend connecting with Dr. Al Power, and he has wonderful books. He's a thought leader, and he has wonderful books, Dementia Beyond Drugs and Dementia Beyond Disease. And in a simplified way, of course, he said, we are not trying to get rid of behavioral distress. The real goal, what we're trying to do is to create well-being. And he developed with the Eilon Alternative 7 domains of well-being. And when you are proactively meeting them in an anticipatory, individualized way, you will guarantee see dramatic reduction of these incidents. The book addresses each one of those domains. I want to talk about the role of the physical environment in the prevention of these incidents. Many care homes are designed either as a hospital, no good, or as a hotel, but not elder-friendly or dementia-friendly. Maybe it's good on the architect's portfolio when the chandeliers and the fancy lobbies and the patterns on the floor and all those things that are not user-friendly and unhelpful for older adults and people with dementia. If you want to consult with someone, speak with my colleague, Steve Orfield Labs in Minneapolis. He has many years of experience studying the effects of physical environments on different populations, including older adults and people with dementia. People with dementia, it really works well for them when we have small-scale care homes, such as the greenhouse of the Eilon Alternative with 8 to 10 residents. So small number of residents per living area, not overcrowding settings with 30, 40 residents and severe understaffing. The floor layout is critically important. I'm going to talk about it in a minute. And we need to shift to mostly private bedrooms. I'll elaborate in a minute. We need to make sure that we thoughtfully design elder-friendly and dementia-friendly landmarks, queuing devices, signage, pictograms, to use colors wisely and use appropriate font and contrast that is elder-friendly and dementia-friendly. One care home where I conducted a study on this phenomena had one hallway painted in one color, and the opposite hallway was painted in a different color. And because a subgroup of residents were often looking for their bedrooms in the wrong hallway. Memory boxes to install them by the door of a resident in an individualized, personally meaningful way. We're going to talk about it in a minute. And we need to make sure that the hallways are clutter-free from information and objects that can distract the resident or could be a fall risk. We must ensure to avoid flooring with patterns, reflective shine and glare. We need to avoid construction of hallways with dead ends because some residents with dementia are unable to retrace their steps. We need to keep it quiet and to minimize noise, which is extremely difficult for many residents with dementia, and they're very sensitive to noise. The average noise level in nursing homes in America is much higher than the recommended standard, as Steve Orfield tells us. And again, assistive technology. How can we develop innovative technologies to assist staff to detect residents about to enter another resident's bedroom in real time? For additional guidance, you can refer to this Alzheimer's Knowledge Exchange resource at the bottom of the slide. So here we have 2 floor plans. I'm going to talk about the importance of direct line of sight of staff to residents. Let's look on the floor map on the left-hand side for a minute and focus on the arrow on the upper left-hand side highlighted in yellow. Imagine there's a resident with dementia about to enter that room right there on the upper left-hand right corner. And staff members, who are often understaffed, are providing care or are around the bedroom that is in the lower right corner of the care home where about 30 residents live. What are the chances for that staff member to even know that this unwanted entry is about to occur? Moving to the floor plan of the Eden alternative, the first greenhouse in Tupelo, Mississippi, and please ignore the yellow part and the lower left side of the floor map. In the perimeter, you see in brown, the 10 private bedrooms and private bathroom. Talk about dignity. If you are a director staff member and you standing in the center, in the living area there by the kitchen, you are much more likely to be able to detect in real time that a resident in advanced stage of dementia is about to enter the bedroom of another resident. How can we shift towards those care settings that truly are more home-like in their architectural design that could also enable residents to remain safe? So direct line of sight. We also know from studies that special care units have higher risk of these incidents. The study in Massachusetts, Harvard study in Massachusetts that I mentioned earlier, discovered that those Alzheimer's units had almost 3 times as likely, residents had 3 times as likely to be injured in those incidents compared to traditional care settings. I don't like the term special care units because many of them are not special. In fact, there's a whole spectrum of quality, anywhere from a locked door all the way to a full and ongoing endless commitment to a true culture change journey related to care for people with dementia. Here are the memory boxes that were shown in research studies to increase residents with dementia ability to locate their bedrooms. Staff members must be encouraged to regularly move around the unit and not congregate in one spot. And there's a tendency to do that. As an experienced, very compassionate and effective team leader in my early studies said, CNAs always have to be alert. If you are not alert, you could miss something. Someone could fall, or someone could have a heart attack. Walking from point A to point B in the care home, the doors may be open. I am looking inside the room to see there is no resident on the floor. Always focused and always looking out, because things can happen. They can happen fast. So as I mentioned earlier, there's a need to shift to mostly private bedrooms. In British Columbia, Canada, for over 20 years, there's a requirement in the law for publicly funded nursing homes to provide private bedrooms, newly constructed settings. However, why mostly? Because some residents can benefit from a roommate, support, companionship, friendship. Even roommates can alert staff when something happens, whether it's medically or otherwise. And so we always have to dedicate certain bedrooms to 2 residents, but not more. And we also have to think about spouses and partners that need to be accommodated. And this was acknowledged in the 600-page report by the Academies of Sciences, Engineering, and Medicine last year. Other areas for consideration, real quick, really important to conduct pre-admission behavioral assessment and never admit a resident for the bottom line. Never admit a resident you're unable to care for safely. So many residents have been injured and died as a result of this practice. Operate only within scope of practice and use available screening and assessment tools. Some of them I developed, and because they are the basis for individualized care plans. We must commit as a sector to a learning culture, not only within your organization or your chain. We need to learn from each incident, including near misses, and share it across buildings, beyond counties, beyond state borders, beyond countries, as we've seen today. We need to strengthen government oversight and owner and care provider accountability, and we need to criminally prosecute for gross neglect resulting in injuries and death in those incidents. And with the eye into the future, a national expert, Dr. Paul Rea, wrote in 2006, due to the approaching retirement of the baby boomers and the estimated growth of older adults with dementia, we are going to see increasing incidence of this phenomena. There will be more and more pressure from family members and advocacy groups to keep the residents safe. Just want to mention that I wrote a book on, and hope that it will help understand and prevent these incidents. And you can access it on Health Profession Press website. Before closing, I want to just mention that it is the right of older adults to live in safe care homes, as we all expect to remain safe in our own homes. And just quickly mention that here's the list of studies and reports and articles and newspaper articles and interventions that you can find at the end of this presentation. And there's some extra slides that you can explore later in your time. So I want to thank you for taking the time to join us today. And I would love to continue the conversation. And if you have any suggestions, insights, or anything that you find that works in your care setting or otherwise in your experience, I would love to hear from you. My email is on the opening slide here. So thanks again, and we'll bring it back to Chris.
Wow, very disturbing eye opener, and thank you so much, because we do need to be aware of these things. Also, thank you for bringing up the need for more private bedrooms, more rooms. So many of these poor folks are crammed together in a closet-sized space and sharing it, with a curtain between them, not able to personalize their room or anything. In your research, were there a lot of incidents of roommates, a conflict between roommates?
Yes. So my study found that, if I remember correctly, and it's on the slide, it's about 43% of the fatal incidents that I examined occurred between roommates. And we know it also from hundreds of other fatal incidents and injurious incidents internationally.
Is this really kind of boiled down to, well, several things? Unwillingness to give the resources necessary to provide adequate quality care, and especially considering how much we devote to quality care of our children, which is absolutely right. But there seems to be a very, very different standard for our older folks.
Absolutely. For decades, leading national advocacy organizations such as the National Consumer Voice for Quality Long-Term Care were advocating for minimum safe people-to-people ratios. And unfortunately, the industry pushed back, even with the big regulatory change that occurred between 2016 and 2019. And it remains a requirement for sufficient staffing. And that's left to the discretion of the owners and administrators. We have to remember that nationally, nearly 70% of nursing homes are for-profit, and even a higher percentage of assisted living are for-profit. So it has to do with not putting the resources up front for people-to-people ratios, the specialized training, the risk assessment, the meaningful engagement program. Some places you come at 2 p.m., no more activities. And that's exactly where a lot of the restlessness and those incidents occur, all the way into the evening and the night. So we need to be more proactive, and it's not rocket science, and you can prevent the majority of these incidents, but it requires commitment by owners. Owners of long-term care homes need to become aware of the serious consequences that could occur. And in fact, 2 incidents that resulted in fatalities resulted in $1.2 million settlement, and then another $1.9 million settlement. And I'm asking, isn't it better to invest a fraction of that in a proactive prevention?
That is the heart of it, isn't it? And you've demonstrated once again how very important it is to have advocacy groups like Elder Voice Advocates and National Consumer Voice out there. First of all, educating people, and thank you today for doing exactly that. And then to push for systemic regulatory oversight that makes sense. Unfortunately, there's a need for government to be involved, because we've seen that especially the for-profit entities have a very poor track record of providing quality care.
Mm-hmm.
Thank you. Thank you.
Yeah, can I relate to that real quick?
Yeah, go for it.
It is hard to believe, and yet not, that the Centers for Medicare and Medicaid Services that oversees care and safety in over 15,000 nursing homes nationwide still doesn't track this phenomena. It doesn't track it in its state server deficiency FTAG system, and it doesn't track it in the minimum data set 3.0, which is a federally mandated clinical assessment and care planning data set that is often used for research. So when a phenomena so harmful psychologically, injurious incidents, deadly incidents in similar circumstances not being tracked, essentially it doesn't exist. And when it doesn't exist, you're not in a position to address it. So I really urge CMS and also the assisted living sector to take leadership on this front and prevent the next injury and death of a vulnerable and frail older adult and those with dementia.
Thank you, Eilon Caspi. A wonderful presentation, and we do appreciate that. And with that, I'll say goodbye.
Thank you, Chris.
Thank you.